Hypertension is the major risk factor for cardiovascular disease and all cause of mortality. Around 30 to 40% of the world's adults had hypertension. Most of them have primary hypertension, which is related to the age, lifestyle, genetic, and environmental factors. But approximately 15 to 30% of hypertensive population has secondary cause, such as primary renal disease, oral contraceptive use, sleep apnea syndrome, congenital or acquired cardiovascular disease, and excess hormonal secretion. In young adults less than 40 years old, the prevalence of secondary hypertension is 30%. Endocrine conditions as a cause of secondary hypertension comprise more than 5% of all patients with hypertension. Although this form of hypertension is rare, but the diagnosis and treatment of underlying cause may cure or at least cause significant improvement in blood pressure and reduce the complications. Now, the criteria for diagnosis of hypertension. According to American Heart Association, normal blood pressure defined as systolic blood pressure less than 120/80, elevated between 120 to 129 for systolic and less than 80 for diastolic, grade 1 between 130 to 139 for systolic and 80 to 89 for diastolic, and grade 2 more than 140/90. Other guidelines, they use different classification, but regardless the classification of hypertension, all guidelines, they use same threshold for pharmacological treatment initiation. According to American Heart Association, they recommend to start medical therapy for primary prevention if patients have blood pressure more than 140/90 without clinical cardiovascular disease and the risk of cardiovascular disease in 10 years less than 10%. And for primary prevention, more than 130/80 if blood pressure and patient has cardiovascular risk more than 10%. And for secondary prevention, if patient have heart disease and blood pressure more than 130/80. And they mentioned it's better to start treatment for specific comorbidities regardless the cardiovascular risk if the blood pressure more than 130/80, including diabetes, chronic kidney disease, microalbuminuria, heart failure, lacunar fraction, and peripheral artery disease. We have another form of hypertension, which is called resistant hypertension. Resistant hypertension defined as blood pressure is not on the target with 3 medication, one of them diuretics, and with the optimal dose, or if the blood pressure is controlled with 4 medication or more. Before diagnosis of resistant hypertension, it's better to exclude pure blood pressure technique, pure adherence, correction dose, the regularity of medication, and exclude white coat syndrome, which is very common, the prevalence of white coat syndrome around 20 to 30% of population. This study investigated the effect of the doctors and nurse visit in blood pressure. They found that blood pressure goes up in the first minute of the visit to 20/16 for doctors, and come down to normal pressure after 10 minutes for nurse visit. So blood pressure measurement should be by nurse and at least 10 minutes after the visit. Now, who should be investigated for secondary hypertension? Young patient with age less than 40 years without risk of primary hypertension like obesity, metabolic syndrome, family history. New or sudden onset of hypertension before age 20 or after 50. Resistant hypertension, severe hypertension more than 180/110. History of hypertension, emergency or repeated severe urgency. Sudden alteration in blood pressure control. History of family history of early onset hypertension or CVA at age 40 and below. And if there's any abnormalities in the test results, suggest secondary cause like hypokalemia, hypertension with adrenal incident role. Endocrine hypertension. Hypertension may be the initial presentation for at least 15 endocrine disorders. We have cause related to the adrenal, including Pheochromocytoma, primary Aldosteronism, Cushing syndrome, hyperdeoxycorticosteronism, including congenital adrenal hyperplasia, 11-beta hydroxylase deficiency, 17-alpha hydroxylase deficiency, deoxycorticosterone producing tumor, primary cortisol resistant. For pituitary, we have acromegaly, Cushing syndrome, For parathyroid, we have hyperparathyroidism, and for thyroid, we have hypohyperthyroidism. We start with adrenal cause with pheochromocytoma. Pheochromocytomas are rare neuroendocrine chromophene cell tumor that usually produce catecholamines. Pheochromocytoma was found to be less than 1% of patients who were evaluated for hypertension. Hypertension in pheochromocytoma usually sustained in 50%, and paroxysmal in 30%, and 20% is normal. So we have form of pheochromocytoma, which is called normotensive pheochromocytoma. It's very important to recognize and diagnose this form of pheochromocytoma. The normotensive pheochromocytoma behavior during the surgery is similar to hypertensive pheochromocytoma and need treatment or need the preparation with alpha and beta blocker before the surgery. For that reason, all guidelines recommend to screen for pheochromocytoma in all the adrenal mass, regardless blood pressure high or not. However, 25% of pheochromocytomas occur within a family disorder, such as MEN2, von Hippel-Lindau, or neurofibromatosis. In MEN2P, patients usually present with family or personal history of pheochromocytoma, medullary thyroid carcinoma, and mucosal neuromas in lips or tongue. In MEN2A, usually patients present with family or personal history of pheochromocytoma, hyperparathyroidism, medullary thyroid carcinoma. In neurofibromatosis type 1 or von Recklinghausen disease, usually patients present with axilla Franklin coffee spot in the skin, nodules in the iris, which is called leech nodules, and cutaneous neurofibroma. In von Hippel-Lindau, patient usually present with pheochromocytoma, renal cell carcinoma, family history of renal cell carcinoma, hemangioblastomas in the brain, and retina. There's no agreement about the genetic test in all patients with pheochromocytoma. Some guidelines recommend to do the genetic test for all patients, and others do not. Clinical presentation. More than 90% of patients with pheochromocytomas present with 2 out of the 3. Headache, described as severe, rapid in the onset, and bilateral headache, sweating, palpitation, occurs in spells that last from several minutes to 1 hour. Some patients present with pallor, nausea, tremor, orthostatic hypotension, and mass effect from the tumor. Some patients present with dilated cardiomyopathy, which result from long-standing catecholamines excess, acute myocardial infarction from the coronary vasospasm, and arrhythmias. Some patients present also with unexplained pulmonary edema. We have to know that flushing is not typical for pheochromocytoma. It's typical for carcinoid or hot flush. Usually, patient with pheochromocytoma is pale, not red. However, pheochromocytoma's diagnosis is frequently missed. In 54 autopsy-proven cases of pheochromocytoma seen at the Mayo Clinic over the 50 years period, 76% of pheochromocytoma had not been suspected clinically. Hypertension, non-specific symptoms such as headache, sweating, and palpitation were a common finding in 54% only. So who should be screened for pheochromocytoma? Any patient with paroxysmal signs or symptoms, even slight clinical suspicion of pheochromocytoma, should permit biochemical testing. Resistant hypertension, partial response during anesthesia, surgery, angiography, or certain drugs like tricyclic antidepressants, metoclopramide, phenothiazide, and naloxone, or some foods that contain tyramine, such as aged cheese or red wine. Patients who have paradoxical rise in blood pressure in response to beta blocker therapy. Onset of hypertension in young ages than 20, and patient with adrenal incidental. Screening test. For screening of pheochromocytoma, usually we use plasma-free metanephrine and normetanephrine. They have high sensitivity, 97 to 100%, and high specificity around 82 to 96%. Second line, we can use 24 hours metanephrine and normetanephrine. It's better to avoid vinyl mandelic acid, catecholamines in the urine, and plasma chromogranin A. They have low specificity and sensitivity. Normal result rule out pheochromocytoma, and high result more than 3 folds can confirm the diagnosis. For plasma-free metanephrines, blood should be drawn after resting in the supine position at least 30 minutes. This is the algorithm of diagnosis pheochromocytoma. First line, free metanephrine and normetanephrine in the plasma. If it is normal, we can rule out the Pheochromocytoma. If it's high, more than threefold, can make the diagnosis. If it's in gray zone, in a higher side, and less than threefold elevation, in this case, it's better to exclude or rule out that medication which can cause false positive, like antidepressant, acetaminophen, or SSRI. If patient doesn't take this medication, we can repeat the test again, or we do methamphetamine catecholamines ratio in the plasma, or we can do clonidine suppression test. If it's suppressed more than 50%, that means patient doesn't have pheochromocytoma. If it's not suppressed, so pheochromocytoma diagnosis should be established, and we send patient for localization. For localization, the first line of imaging, we have CT scan and MRI for abdomen, and they have same sensitivity and specificity. Pheochromocytomas are usually large, between 2 to 5 centimeters, and may have areas of hemorrhage and necrosis. Sometimes we use nuclear study or nuclear imaging, like meta-iodobenzylguanidine, has almost 100% specificity but limited sensitivity. Octreotide scintigraphy, it can detect pheochromocytoma in less than 30% of cases. 18-fluorodopamine has sensitivity up to 100% of pheochromocytomas. But usually this type of a study should be done for patients with malignant pheochromocytoma and metastasis, or for paragangliomas. First line is only CT or MRI. Treatment of pheochromocytoma: surgery, laparoscopy, adrenal laparoscopic. We have to prepare patient with alpha blockers and beta blockers before the surgery. Screening for hypercortisolism or Cushing syndrome. The mechanism of hypertension include increased production of deoxycorticosterone, which is a strong mineral corticosteroid. Activation of the renin-angiotensin-aldosterone system by increased hepatic production of angiotensin, and cortisol activation of the mineral corticosteroid receptors. Usually we have two types of Cushing syndrome: ACTH dependent and ACTH independent. ACTH dependent refers to pituitary adenoma or ectopic Cushing. ACTH independent to adrenal tumor. Regardless the etiology of Cushing, 75 to 80% of patients with Cushing syndrome have hypertension. Typically is mild, but 15% had blood pressure more than 200/120. Patients with Cushing syndrome may present with many non-specific symptoms and signs. They can present with diabetes, hypertension, osteoporosis, obesity, acne, hirsutism, fertility. So the symptoms and signs of Cushing syndrome is very common and non-specific, and this is very rare. So the routine screening for Cushing syndrome is not recommended. For that reason, we focus on overt Cushing. Overt Cushing refers to patients who have specific symptoms and signs of Cushing, such as easy bruising, facial plethora, proximal myopathy, purpose cilia more than 1 centimeter in wide. So who should be screened for Cushing? All patients with hypertension who present with signs or symptoms consistent with the clinical presentation of Cushing syndrome, I mean overt Cushing, and all patients with adrenal incidentalloma, even without signs or symptoms of Cushing syndrome, to detect pre-disease or subclinical hypertension, which can increase the mortality and morbidity in long term. Evaluation for Cushing syndrome evaluation, we have 3 steps. First, we have to confirm there's hypercortisolism, chronic hypercortisolism. Then we have to know, is it ACTH dependent or ACTH independent? Third step, localization. For confirmation of hypercortisolism, we have 5 tests. If two tests is positive out of 5, we can establish the diagnosis. We have 1 milligram overnight dexamethasone suppression test, midnight salivary cortisol, midnight blood cortisol, low dose dexamethasone suppression test or Lidl test, free cortisol in 24 hours during collection. For patients who have overt Cushing or symptoms and signs of Cushing, we have to do at least 3 to 4 tests over this 5. And we have to also to repeat the test at least 2 times, each test 2 times, to confirm the diagnosis. But for patient who doesn't have specific symptoms, like some patient with obesity and diabetes, some patient with polycystic ovarian syndrome, this type of patient could be evaluated for Cushing syndrome. So in this case, it's enough to do 1 milligram dexamethasone suppression test. If it is negative, we can exclude that disease. Second step, we do ACTH. If ACTH is low or subreddit, less than 5, so it's adrenal tumor, and we send patient for CT or MRI of abdomen. If ACTH is high or normal, more than 20, so it looks like ACTH dependent, pituitary or ectopic. In this case, we do MRI for pituitary. If we have macroadenoma, so we can consider this tumor as the source of ACTH. But if we have small adenoma or less than 5 millimeter, as we know that non-functioning microadenoma is very common in the population. Around 10% of my population had small adenoma in the pituitary, and it's not non-functioning. So how we can differentiate between the ACTH producing pituitary adenoma, even if it is small and ectopic? Usually, we do high-dose dexamethasone suppression test. We give 8 milligram dexamethasone, and second day we see suppression of cortisol. Or we do inferior petrosal sinus sampling. If it is negative, so that means this is ectopic Cushing. We send patient for CT, pelvis, abdomen, chest, and neck. Treatment of Cushing syndrome. For pituitary adenoma, usually surgery. If relapse, we send patient for radiation. For ectopic STH syndrome, surgery if it's possible, but usually this type of tumors is very small and invisible in the imaging. For that reason, we use drugs that block stereosynthesis like ketoconazole, metrabone. In severe relapse cases, we do bilateral, send patient for bilateral adrenal. For adrenal tumors, also adrenalectomy. And in malignant adrenal Cushing, we use metotrol. Screening for primary hyperaldosteronism. In primary aldosteronism, aldosterone production exceeds the body's requirements. Excessive unregulated production of aldosterone results in increased sodium reabsorption by the kidney, hypertension, renin-angiotensin II suppression, and urinary loss of potassium and hydrogen ions. In general, we have hypertension, hypokalemia, and alkalosis. Primary aldosteronism has a variable prevalence ranging between 5 to 14.4% of all hypertensive patients. But not all patients with hyperaldosteronism are hypokalemic. Only 20 to 40% of the patients had hypokalemia. 60% present with normal potassium. Usually, patients present with symptoms of hypokalemia if he has hypokalemia. Cramps, numbness, weakness, nephrogenic diabetes insipidus, palpitation. Also, the prevalence of obstructive sleep apnea is increased in patients with primary aldosteronism, and it improves with the primary aldosteronism specific therapy. Rates of cardiovascular events, arrhythmia, myocardial infarction, stroke, cardiovascular mortality are higher in patients with primary aldosteronism than among those patients with primary hypertension matched for blood pressure level. We have many subtypes of primary aldosteronism. Aldosterone producing adenoma, idiopathic hyperaldosteronism or bilateral hyperplasia, which is the commonest cause, primary adrenal hyperplasia or unilateral hyperplasia, glucocorticosteroid remediable aldosteronism or familial hyperaldosteronism type 1, adrenal, this is very rare disorder and inherited disorder, adrenal carcinoma. So who should be screened for primary aldosteronism? All patients with resistant hypertension and spontaneous or diuretic-induced hypokalemia, especially thiazide. Thiazide-induced hypokalemia strongly suggests hyperaldosteronism. Hypertension and adrenal trauma, hypertension with obstructive sleep apnea, hypertension and family history of CVA at young age less than 40. And we have two cases, same history. Evaluation of primary aldosteronism. First line of screening test is aldosterone-renin ratio. When aldosterone levels measured by nanogram per deciliter and renin measured by nanogram per milli per hour, this ratio is usually less than 20 in normotensive subjects, primary hypertension, and in secondary hyperaldosteronism, like heart failure or renal artery stenosis. If the aldosterone level more than 15 and the ratio more than 30, this test has 90% sensitivity and 91% specificity, but we need to go for further evaluation and confirmatory test. If the ratio more than 50 or more than 9.6 when we use direct renin concentration, not renin activity, this threshold is diagnostic for primary aldosteronism and no need further biochemical evaluation. In 2016, Endocrine Society guidelines suggest that patients with hypertension, hypokalemia, undetectable renin, and plasma aldosterone concentration more than 20 may not need further biochemical evaluation, and we sent him for localization. Confirmatory test, we send patient for confirmation for the further biochemical test if they have slightly elevated aldosterone and borderline elevated ratio. Usually we use fludrocortisone suppression test, saline loading test, oral salt loading test, captopril test. We expect suppression of aldosterone after administration this agent in a normal patient or patient without hyperaldosteronism. It's very important to distinguish between adrenal adenoma and bilateral hyperplasia, because the unilateral adrenalectomy in adrenal adenoma or aldosterone-producing adenoma cures 69% of patients of their hypertension and reverses hypokalemia in all patients. On the other hand, bilateral adrenalectomy in adrenal hyperplasia cures hypertension in only 90% of patients, while also reversing hypokalemia in all patients. For that reason, surgical removal of aldosterone-producing adenoma is preferred, and pharmacological therapy in hyperplasia is the treatment of choice. As we know, in elderly age, the adrenal or non-functioning benign adrenal adenomas is very common. At age more than 50, the prevalence of adrenal adenomas non-functioning and benign around 10%. So if we have patient with biochemical evidence of hyperaldosteronism and in imaging, we have adenoma. So how we can differentiate between hyperplasia or the producing aldosterone? It could be non-functioning adenoma and patient had underlying hyperplasia. So for that reason, usually we send patient for imaging for CT and adrenal venous sampling. In general, adenomas are usually solitary, but rarely may be bilateral. They are usually less than 2 centimeters in diameter, with mean diameter ranging from 1.5 to 2 centimeters. To differentiate between hyperplasia and aldosterone-producing adenoma, it's better in elderly age to send patient for adrenal venous sampling for localization. This is the algorithm of hyperaldosteronism. After diagnosis of hyperaldosteronism, we send patient for adrenal CT or MRI. If we have adenoma more than 1 centimeter and patient age less than 35, the non-functioning benign incidentaloma or adrenal adenomas is not common in this age group. So we can directly send patient for surgery and consider this is the source of aldosterone. But if the age more than 35 and in some guidelines more than 40, it's better to send patient for adrenal venous sampling. If we have normal adrenal in the CT, or we have nodule less than 1 centimeter, which is not classical for aldosteronism, or bilateral masses, it's better to send patient, regardless the age, to send patient for adrenal venous sampling. Actually, the term of hyperplasia refers to activity or function. It's not related to the appearance of the CT scan. So it could be there's hyperplasia and normal adrenal in the CT. Treatment: unilateral laparoscopic adrenalectomy in the patient with unilateral forms of primary aldosteronism, adenoma, or unilateral adrenal hyperplasia cures hypertension. We need to start aldectomy 4 to 6 weeks before the surgery. 50% of patients become normotensive in 1 month and 70 in 1 year. For non-surgical patients, like the patient who have bilateral hyperplasia, medication that antagonize aldosterone action, like aldosterone, eperinone, and amiloride, it should be used. There may be a delay in response to hypertension around 4 to 8 weeks, and 70% of patients need another antihypertensive agent. Hypothyroidism. Hypertension and hypothyroidism usually diastolic. The frequency of hypertension is increased threefold in patients with hypothyroidism. Hypothyroidism can lead to volume-dependent blood pressure elevation with low plasma renin concentration related to the dilatation of the plasma and increased systemic vascular resistance. The reversal of hypertension was found in one-third of hypertensive hypothyroid patients following normalization of the thyroid status. Subclinical hypothyroidism seems not to be associated with hypertension. Who should be screened? All patients with hypertension and clinical features of hypothyroidism like dry skin, cold intolerance, constipation, weight gain, goiter, and family history of thyroid disease. Diagnosis, usually we use TSH and free T4. If TSH is high and free T4 is low, that means that we have primary hypothyroidism related to the thyroid disease, like Hashimoto. If we have normal low TSH and low free T4, we have central hypothyroidism related to the pituitary disease. If the TSH is high and free T4 is normal, this is subclinical hypothyroidism. Hyperthyroidism. In hyperthyroidism, systolic blood pressure is elevated, and diastolic is usually lowered as a result of peripheral vasodilatation, leading to a widened pulse pressure, so-called isolated systolic hypertension. The prevalence of isolated systolic hypertension in hyperthyroidism is reported to be between 20 to 30%. In one-third of patients, hypertension resolves after achieving euthyroidism. Treatment of this type of high blood pressure, we prefer beta blocker to treat both symptoms of hyperthyroidism and hypertension. Hyperparathyroidism. Primary hyperparathyroidism is hypercalcemic disorder resulting from parathyroid adenoma in 80% and parathyroid hyperplasia in 15 to 20%. Prevalence of hypertension associated with hyperparathyroidism varies from 25 to 70%, but in most studies exceeds the prevalence of primary hypertension in the general population. So there is a relationship between hyperparathyroidism and hypertension. On the other hand, many patients with primary hyperparathyroidism may also have primary hypertension. However, the mechanism of these observation association are unclear, and hypertension is usually not cured or better controlled after parathyroidectomy. So all patients with hypertension and hypercalcemia should be screened for hyperparathyroidism. Diagnosis, usually we diagnose hyperparathyroidism when we have normal or high PTH, high calcium, low or normal phosphorus, and high calcium in 24 hours urine. It's very important to do 24 hours urine calcium because we have another form of this disease, which is called familial hypercalcemia, hypocalciuria. It presents with mild elevation in VTH and mild elevation in calcium, and this is inherited benign disease and doesn't associated with any complications in the future and no need any specific treatment due to inactivation mutation in calcium sensing receptor in the kidney and parathyroid. In primary hyperparathyroidism, usually we see high calcium in 24 hours urine and the calcium creatinine clearance ratio more than 2%. In familial hypercalcemia, hypocalciuria, usually we see low calcium in 24 hours urine and the calcium creatinine clearance ratio less than 1%. Treatment of hyperparathyroidism is surgery. Acromegaly is a rare disorder with a prevalence of 40 to 70 cases per million. Hypertension is present in 25 to 50% of patients with acromegaly, a 3 to 4-fold increase in prevalence over the general population. Hypertension is usually mild to moderate and is associated with sodium retention. So the first line of the treatment is diuretics. Patients with acromegaly may present with coarse features, may present with broadened extremities, widened, thickened, and stubby fingers, thickened soft tissue, widened and thickened nose, prominent cheekbones, forehead bulges, thick lips, and marked facial lines. Who should be screened? All patients with hypertension with pituitary adenoma or pituitary lesion. all patients with typically clinical findings of acromegaly, and all patients who have several comorbidities like sleep apnea, type 2 diabetes, joint pain, carpal tunnel syndrome, and excessive sweating. Diagnosis of acromegaly, screening test is insulin-like growth factor, IGF-1. If it is high, we confirm the diagnosis by growth hormone suppression test with oral glucose tolerance test. Treatment of acromegaly, surgery, and we know that disease tends to relapse and recurrence again. In this case, we give octreotide or radiation or third-line big measurement medication. In conclusion, secondary hypertension are more associated with morbidity and mortality than primary hypertension. Routine screening of patients for secondary hypertension would be too costly and is not recommended. Identifying secondary hypertension can be beneficial for patients in certain situations because it may lead to specific treatment and allow better control of blood pressure and sometimes even a cure. The most important endocrine condition to evaluate in the workup for secondary hypertension is primary aldosteronism, which often presents without specific symptoms or signs. Thank you.